I guess in brief, this year's topic is, aside from trauma, is going to be bike injuries. We're going to talk about that in the first half of the hour, and then in the second half, we will do our sort of review of trauma and trauma protocols. So this is probably the most notable bike crash of the last month. There we go. I think so. And when people are sort of injured multiples at a time, it really catches the headlines. This is actually not as rare as one would think. This is the scene from Searchlight, Nevada, which is apparently outside of Las Vegas. This is just 6 months ago. It briefly made national news, but it's frequent enough that it is something I think we've become accustomed to. In this particular accident, a panel truck plowed into a group of 20 cyclists, and 5 of them died, and 6 of them were hospitalized. So the driver was subsequently found to have methamphetamines in his system and to have been on his phone at the time. All of these things contribute, but it's more of this isn't how we get to record numbers of injuries, right? If you look at the history of auto safety in this country, fatalities on the road have been in a steady decline since the early 1970s, right? There was a time we were losing 50,000 people a year on the roads, and now we're under 30,000, and the population's doubled. So we're definitely doing better on the auto end. Okay, and this graph is just looking at the last 12, 13 years. And the data lags a little. You can see here we end in 2018, but the data lags a little, as all these things do, because they need to be collected. Now, this is auto fatalities, but sadly, this is bike fatalities in the same time period. Okay, and like everything else, it dips up and down, but it's definitely trended up over the last 10 years. 2018 was the deadliest year for cyclists in this country since 1990. If you look at the two graphs side by side, you can see that, yeah, there was a bump in overall fatalities, sort of 17, 18, but certainly this is exceeded by, especially if you look at the scale, exceeded by the bump in fatalities among cyclists. So what contributes to all this, right? Why is this? And when we talk about motor vehicle deaths in this country, motor vehicle deaths, if you're inside the car, if you're a pedestrian, or if you're a cyclist, that's all in the denominator, okay? So if you look at it, again, here's some lagging data, but if you look at this as cyclists as a percentage of total fatalities, right? These are small rises from 1.8 to 2.3, but you can see it's kind of reproducible, right? It stays pretty steady, keeps coming up. Now, you could make the counter argument that the denominator is dropping, right? Total fatalities continues to go down. So maybe cyclists are going to represent a greater number of that. But that's not the case, right? Because this number continues to rise. And as I said, 2019 was the worst. Or 2018 was the worst to date. Now, like everything else, there's risk factors. So do you think for cyclists, it's better to be male or female? It's almost never better to be male. Okay? No, I mean, if the question is trauma epidemiology, the answer is male. Okay? The judgment gene must be somehow X-linked. So fatalities are way higher in males, okay? Would you rather be in an urban setting or a rural setting? Rural is correct. You're more likely to get killed in an intersection or not in an intersection? Intersection, right? I mean, right? You're doubling your odds. That's serious. You know, it's not. Now, on the other hand, but if you look at it, and you look at intersection and non-intersection actually account for more fatalities, but you spend much more of your time not in an intersection, right? This is a denominator problem here on this side, okay? The urban setting, again, probably a denominator situation because in an urban setting, there's more people and more people on bicycles, okay? Daylight and dark, you assume, we make the assumption that people are on their bikes more during the day, right? So if we assume that they are on their bikes more during the day, then you're equally likely that it would appear that riding at night is an independent risk factor, right? Makes sense. And then you can break it down by weekday versus weekend and time of day. You can see, as you might expect, there's a little bit of a spike, what is probably the AM commute here, right, on weekdays, and there's a spike in what is probably the PM commute on weekdays. And then on the weekends, there's an evening spike, right? And we'll get to some of the issues surrounding that in a second. All right. There we go. Now, out of these, let's say, demographic groups here, who do you think is most likely to die on their bicycle? By the way, if you get, like I said, with these statistics, if a child gets backed over by their parents in the driveway, and they're on a bike, that's a cycling fatality. The same as if someone gets, slaps into a tree on a mountain bike or is hit on the road. Those are all considered cycling fatalities. Which one of these people is most likely to be killed on their bicycle?
It's not Napoleon because he's quite a
It's not Napoleon. Dude, nice bike.
I'd say like the more, like the group with the jerseys, like longer rides, over more complex roads.
All right. Yeah, it's males. It's white males. It's white males between 40 and 70. Okay. It's Dr. Grice. Okay. Right. You spend $10,000 on a bicycle, but still only spandex between you and the pavement. So this is very much from a statistical standpoint, that is the group most likely to perish. And we keep talking about perishing because presumably, that's the worst case scenario. So let's talk about the fatalities. Here you see, now if you look at the fatality rate, right-hand column, right? And this is your likelihood of dying. Again, it's 40 to 70. The fatality rate here is the highest of all of the age groups. And then interestingly, it's broken out by male and female. And the male numbers just dwarf the female numbers. Okay, it's crazy. So that points to demographic. Now that's fatalities, but what about we don't treat the fatalities, right? We treat the injured. Who's most likely to be injured? Well, then it's people between the ages of 10 and 30, right? And these injuries, we'll talk in a minute about what these injuries are, but it's younger people more likely to be injured, older people more likely to be killed. And again, you may have a denominator problem. Federal, you said that like these guys are out for like 70 miles a day, right? And they're telling you about it in clinic. But yeah, they have more exposure, right? More exposure to risk. These are the 4 states where you are most likely to perish on your bicycle. And you think to yourself, well, okay, those are also the 4 most populous states, right? Denominator problem? Not exactly. These 4 states represent 23% of the population of the United States. They represent 47% of the fatalities. Okay. Could have something to do with population density. That's a potential confounder here, but those are the 4 highest fatality states. Really struggling with the shifting here, sorry. Okay, what about the role of alcohol? Okay, it turns out, and this is apparently if you're going for a bike ride and 15.5 gallons of beer is not enough, there's room for a second barrel of beer. Alcohol of the fatalities, and this is the only time I recorded, Alcohol is involved in 16% of the fatalities. As you might imagine, that is overwhelmingly on the part of the driver, but they are lumped together, either the driver or the cyclist. If you're curious, if it's illegal to drive to operate a bicycle while intoxicated, that varies by state. If you're curious just out of intellectual curiosity, it's illegal in this state. But according to the NHTSA thing that I found all this on, it's illegal, but rarely enforced. Like nobody ever gets charged with it. So yeah, this breaks it down essentially by driver's blood alcohol versus cyclist blood alcohol. But essentially the bottom line is either the driver or the cyclist was drunk in approximately 16% of the cases. Okay. Now this is all you can see. This is, and for those of you that are new here, this is the old standard for blood alcohol content for operating a motor vehicle. That is not the standard in this state anymore. The standard in this state is now half of that. So, about mountain biking versus road biking, which are you more likely to perish on, a mountain bike or road bike? Road bike. Everyone knew that answer right away. Why do you suppose that is? Cars, right? Right. I like cars. Which one are you more likely to get injured on? Not like it's not close. It's not per mile. It is not close. So, what about preventing injuries? Do helmets work? Have you guys been reading Accident Analysis and Prevention? Why not? This is a meta-analysis. It's the best one I could find. The helmets help.
Yeah, there's some thought that like helmets for your powering throws like give you a wider berth.
Look, you put yourself in the company of the guys who told me, if I don't wear my seatbelt, I would be killed. Again, it comes back to math, I think, and like the odds of you, assuming you're going to get in an accident, right? You increase your odds. The short answer on helmets is yes, they help. Okay. This slide's from Marchand. It is odds ratios with error bars, and you have head injury, brain injury, facial injury. Your odds of neck injury are slightly increased if you're wearing a helmet, right? But your odds of head injury and brain injury are way higher. And the one you care about, your odds of being dead. And this is the combined, right? Your confidence interval is below 1. So it stops you from being dead, which is a desired outcome. Okay. And this is the same, a different graphical representation. Okay. Now, what hasn't been studied is the use of a helmet if it's not on your head. Also not studied the effectiveness of parachutes when you jump out of airplanes, but presumably this isn't helping her all the time. And I see people, I live in Immigration Canyon, I see people pedaling up the canyon routinely with their helmet strapped to their handlebars. Also an interesting use of the helmet. You're doing something dangerous enough that you think it requires a helmet, but you put your kid on top of the helmet. This is a helmet with handlebars built into it. Okay. Yeah. So that seems like a poor choice, or at least a very selfish one. Damn. What am I doing wrong? Okay. So getting back to this, this trend up in cycling accidents. Okay. There's a number of factors that they play into it. The kind of vehicles that we are in, so SUVs and trucks means SUVs and light trucks, right? They have just ballooned in the market to the place where they have, they are 3/4 of the passenger vehicles sold in this country currently are SUVs or light trucks. I have been told that the number one, according to Andy Burgess, the number one selling vehicle in the United States for something like 40-something years running is the F-150. Okay. And that has always been the case. But then you add SUVs to that and you say, well, why does it matter? Well, here's why it matters. If you get hit by a sedan, you're half as likely to die as if you get hit by an SUV. I don't know that I can explain all of that, but it's true statistically. And in the stuff that's so obvious, maybe it doesn't need to be stated, but these are your odds of dying based on the speed of the vehicle that strikes you. Okay. Steadily since the National Institution of the institution of a national speed limit was an early 1980s phenomenon. But then starting in the late 90s, these started to be rolled back and they continue to be rolled back all the time. So we probably are driving faster. The other thing is distracted driving. I've previously given talks just on this topic. There's an excellent book on the topic based out of Cache County here in Utah and on work by, among others, a scientist here at the U. And it's pretty interesting. And this definitely contributes. Case example, this fellow is 52 years old. He is struck by a Subaru. And as his face approaches the windshield, he swears subsequently that he saw the driver on the phone as he was going through the vehicle. And the driver denied it. They subsequently subpoenaed her phone records and subpoenaed the records of the car. And in fact, she was on the phone at the time. He had a sort of complicated sort of base of femoral neck and shaft. We fixed him this way. We patched, we made this x-ray look nice. I think we made it look nice. Made his x-ray look nice and he's back on his bicycle. But he still sort of is twitchy on his bike, he says. It affects him. And yeah, it makes sense to me. Still has the PTSD. So how does Utah fare in terms of bike safety? I cut off the rest of the stage, just gave you the bottom of the graph. You would get the impression that per million population, we are safer than average, right? I found that quite honestly surprising because this is just per million population. Right? It doesn't, the piece of the denominator it doesn't include is how many people are on their bikes. And I would assume, just assumption, I would assume that more people are on their bikes in this state than in other states. So it has been the topic of a lot of discussion in this area. If many of you know Ken Johnson, works in the operating room, is one of our anesthesiologists. His younger sister, she was a PhD student here at the U. She was struck and killed in Big Cottonwood Canyon. And Ken was instrumental in this state for about 5 or 10 year period in driving bike safety initiatives. And it has been a hot topic here for a long time. Nonetheless, we lose between 5 and 10 cyclists in this state annually. So on the injury front, this is the #2 state in the nation for participation in high school competitive mountain biking. I didn't know that was a thing. Yes, Colorado. Yeah. So 5,000 kids in Utah will compete in NICA, which is the local. And one of our partners, Stuart Willick, he's a non-operative guy. He's actually doing studies on this, if I'm not mistaken. This is something that I really have sort of firsthand knowledge of. So, or you can take out bicycles and put in skiing. So, all right, musculoskeletal injuries, briefly, what do they get? You all know what the number one answer is. Is that scalp fracture or number 2? Distal raise, yeah, cognitive distal raise. And then after that, it's sort of a smorgasbord of sort of equivalent injuries. The one I think that we see with alarming frequency is femoral neck, young person femoral neck, that we see a ton of. But that's probably sampling error because the femoral neck should probably get sent here. All right. So what do we do about it? The things that have attempted to be done about this are awareness campaigns, if that helps or not. Putting in bike lanes. There's even conflicting data as to whether or not bike lanes help. And it's been a real source of controversy in the newspaper, in the local, and there's pushback on both sides. You say people, well, cyclists want the whole road, and they don't, but they roll through stop signs and red lights. And yeah, there's something to be said for that. So I don't know sort of how we get to a safer spot, but as I said, this trend continues to increase. And the preliminary numbers for 2020 were almost as bad as 2018. And the concerning part is there was a lot less motorists on the road in 2020. Like objectively, there was a heck of a lot less motorists on the road in 2020. So that's concerning. Questions on cycling topic, and then we're going to talk about phone. Yes, sir.
Maybe not perfectly related, had an accident that doesn't bring you to the hospital. Sometimes you put your head in the helmet before you.
My daughter was training last night, and one of her teammates crashed and cracked her helmet. So I think that's
Crack makes sense.
right. I don't know short of that. I have no idea. Does anybody know? Is there an answer to that?
You're supposed to have fall.
One fall.
Like a big impact, yeah.
You're supposed to. I mean, I guess I would kind of assume that it physically changes the helmet, right? Yeah.
There's a concept of ceramic shell in it, pretty low energy balls. But they're a lot better than like like this technology, like the shell moves relative to the inner lining.
Right.
And never to resistance by injuries.
Right. The argument in equestrian for a long time was that helmets contribute to neck injury. And that's where the question about neck injury versus head injury first came up in equestrian. And there was people in equestrian that said, you gotta not wear a helmet, which, so. Interesting problem. And such a hard thing to study, right? Because you don't know about the denominator. So, all right. Okay. We are going to try to advance the slides. I'm going to talk to you briefly about our trauma system here. I'm going to try not to bore the seniors to death because I've seen some of this before. You are located right where the star is. This is roughly the area that we serve, if we're being honest about it. There is certainly some overlap between ourselves and University of Washington. We appear to be covering a bigger chunk of Montana than ever before. And we have efforted in that way. You'll see over your time here that you see a whole lot of people from Eastern Nevada and very few people from the Western slope of Colorado. They have a level 2 trauma center in a town called Grand Junction, and a lot of business goes there. And then the stuff in Idaho, what gets distributed here versus to Boise, versus even to Port Neuf is happens sort of on a case-by-case basis, I guess. And the rest of Wyoming throws to Denver. So I'm going to skip most of the geography. There's 29 counties in Utah. If you could learn the names like half of them, that'd be great. These are the congressional districts in Utah. It's called gerrymandering. Okay. AirMed is the name of our, and I say our, I mean the UofU's Air Medical Service. There's two big outfits in this state, AirMed and Life Flights. And these are used interchangeably and generically by the general population. And that makes these guys insane. There's some, I would say, friendly, positive rivalry between the two air medical services, but please refer to our guys as Air Med, because when you call them Life Flight, it's, it's like a Mets Yankees thing or something. It's cringy for them. So, it matters to us. There's data as to whether or not air medical transit actually save lives. It is highly debatable in an urban environment. It is, you can make a much more solid case for it in a widely rural environment like ours. Okay. Our air medical transit service has two bases for fixed wing aircraft, that is to say airplanes. One is in Rock Springs, which is in southwestern Wyoming. And the U also runs the emergency department there. That's why when you look up x-rays from Rock Springs, they're actually in our system, and x-rays everywhere else are, have to be imported. We also have a base at out at the little airport next to the big airport. The big airport is where we all fly in and out of. Next door is the sort of the private airport, and that's where AirMed flies in and out of. I don't know the exact number of aircraft at this time. It appears to change. I've heard this other stars on this map are where we have helicopter bases. Okay, and each one of those bases is managed 24/7. And you can imagine some of them see more business than others. We had at one point a base out in the Great Uinta Basin, which is out here. That's Vernal Duchesne Roosevelt, but that's not the case anymore. I presume at some point we'll end up with a base to the south. The helicopters have a range of 160. The planes have a range of 1,700, right? So essentially, I mean, it tells you something that Rock Springs has got an airplane in it, right? Because that's sort of edge of range. So, and some of the helicopters have a greater range than others. The one that looks like it has tiny wings on it, it turns out there's fuel in those. So, anyway, that's that. That's how a lot of our business gets here. Okay. So let's talk about the trauma service and how it evolved. This fellow crashed a homemade airplane. Okay, bad idea. Not crashing homemade airplanes is a bad idea. And he's got a laparotomy. He doesn't miraculously have a brain injury. He has a colostomy because his open pelvic fracture is diverted. He got his bilateral chest tubes, and his spleen has been removed for him. But the thing that, and I know this fellow to this day, the thing that haunts him is that his left lower extremity doesn't work that well. Okay, right? They're not going to miss their spleen. They're going to miss function. And orthopedics is about function. Okay, so his chief complaint down the road is, I can't do this, that, or the other thing. And we said that trauma is a disease that strikes young people and males. Frequently, the complaint is, I cannot work / support my family. So that's why it's important that we are involved at the very get-go. I will try to keep this story brief. Back in the day, orthopedic surgeons were doing well enough that they had their own airplanes and stuff. All right, just a little too late. But this fellow is an orthopedic surgeon who's flying his family across Nebraska. He turfed it in the wintertime. Family, 4 children, his wife, 2 of them perished, and then the remainder were just redistributed to hospitals about Nebraska. And it was his impression at the time that how they did and their survival depended on where they went. And he set up Advanced Trauma Life Support. It was founded by an orthopedic surgeon. Okay, you have that forever to hold over your general surgery colleagues. It's based on 3 principles. 1, if you act fast, speed saves. 2, you need to have centers of excellence. Single centers where all the trauma goes, or most of the trauma goes. And 3, repetition breeds excellence. Now, you are going to, in the course of the next 5 years, roll your eyes when somebody with a clavicle fracture and a bleeding finger is a level 1 activation downstairs, and you got to respond to it. Okay, but all those resources got activated, and it's just drilling, it's just rehearsing. Okay, there's a great book called Blink by Malcolm Gladwell. It's about how you respond. Sorry, it's about a lot of things. But he covers for a fair bit the value of repetition in how you respond in high stress environments. This, this works for EMTs and ICU doctors and quarterbacks, right? And the more often you've seen it, the less your heart rate elevates, because once you get above a certain heart rate, you are effectively sort of autistic. No, that's not, sorry. I say a lot of things that are inappropriately attempted to be funny, but read this book. Bible goes down on it. The problem, people who with autism, they don't understand, they don't know how to prioritize the inputs. Okay, so you get tacky enough and you no longer capably prioritizing inputs. This is what kills mountain climbers. So ATLS, the Advanced Trauma Life Support, says that if you follow the same thing every time, you're going to miss less injuries and you're going to deliver better care. So trauma in brief is the treatment of shock. What is shock? Any of you have the first two rows here? Yeah, exactly. Both things. We define it as hypotension, low blood pressure. And the end problem is ineffective perfusion of your organs. What are you trying to get? You're trying to get oxygen to the big players, right? The brain, the heart, the lungs, the kidney. That's it. Right? To get through that, you need your heart. And so there's only a limited number of ways that you can influence that. What else will you see in a traumatized patient that indicates to you that they have shock? Besides low blood pressure. Tachycardia. What else?
Changing mental status.
Changing mental status, yeah. Absolutely. What else? The weird thing about changing mental status, right, is it's not pathognomonic, right? A bunch of things give you change in mental status, but it's definitely on the list. What else?
Elevated lactate.
Yeah, elevated lactate, and then we start to, right, and we start with the physical findings, and then we start getting further and further down the basicsness of how we're going to get the data, right? Like no urine output, right? And then blood values like, your base deficit or your lactate, right? Okay. And those are essentially, and again, as we get further and further down the invasiveness tree, those are more and more indicators that we are not getting oxygen to the end organ, right? And so our job in orthopedics is to try to contribute to stopping the shock. Okay? And we don't, there's very few, like if I'm coming between you and a pine box, you're probably most of the way to the pine box. Yeah. So we as orthopedic surgeons have very few opportunities to really be the binary yes, no. But we can certainly contribute to tipping the odds a little in their favor. Yeah? Okay, good. So go through this every year. Someone comes in shock. There's three things that are going to give you shock. What are they? Anybody wants to? Yeah, not enough blood. Hypovolemia. Forgive me. Hypovolemia. Okay. What's that? Cardiogenic and neurogenic. Right. That's it. Neurogenic is your brain or your spine. Right. But that's your differential for shock. You start in trauma assuming which one of those three. Not enough blood. Okay. So there's only 6 places you can bleed. Period. To death. Excuse me. There's only 6 places you can bleed to death. Can you bleed to death in your head? No. Bleeding in your head can kill you, but not from hypovolemia. Why not? Okay. Where can you bleed to death? Thoracic cavity. Pelvis. Can't bleed to death in your extremities, but you can bleed to death out of your extremities, right? So the outdoor world, right? And so the 6 places you can bleed are the 6 places we just mentioned, and the 2 places you can't bleed to death are your head and your extremities, right? So for us, that's our, and And then the other area where we get involved in the differential for shock is in unexplained hypotension, and you've ruled out those 6. Okay, we can't help so much on the cardiogenic aspect, but we have certainly identified neurogenic shock and identified subtle neurologic injuries that are contributing to shock. What is the most likely? You've done the entire tree, and you've got it down neurogenic. What's the most cult injury, neurogenic injury that's going to get you there? It's OC, subtle OC dissociations. Okay. Cranial occipital, cervical occipital dissociations. Okay, that could be subtle, and a large number. I can't remember what the numbers are, Dave. I don't know if you remember. Number of those that are initially missed on diagnosis, right? Because if you present collared, you may present reduced, right, and yet have a ligamentous injury. So it's worth keeping in your differential. I'm not going to talk to you about the grades of shock. There are 3 different types of head injury, and we'll talk about that some other time. It is worth you knowing what goes into the GCS, right? Is the GCS on presentation prognostic? You guys can take a test your whole life. If I ask it that way, what's the answer? No, right? The GCS on discharge from the hospital prognostic. Okay, so you can present with a pretty miserable GCS, and there's too many factors initially for it to be reliable. But the prognostic one is by the time we get you out of the hospital, if you're below an 8, the prognosis is super not good. Also, trauma is different from everything else you're going to do in orthopedics. The reason trauma is different is because it is the unanticipated one, right? People don't anticipate, you could argue people don't anticipate cancer, right? But it still isn't, the diagnosis is given to them like that, but they still have time between diagnosis and treatment to adjust to it. There is 0 time between diagnosis and treatment in trauma, okay? And it is chaotic. We have the impression, and I will give you guys this bit of advice, we have the impression we're treating trauma patients almost that they know as much about trauma as they do, as you do. Now, some of them have previously been a level 1 activation. This happens. But most people, and I have previously made the mistake of surveying the room to see who has been a previous level 1 activation. And it turns out that's a HIPAA violation, so I don't want to know. But most of you have never been a level 1 activation, right? But to be greeted, with people stripping all your clothes off, sticking a needle in your groin, sticking a digit in your anus, and just pawing at you, be pretty shocking for the awake patient, yes? And sometimes the awake patient is altered. So consider the fact when you're interacting with the awake patient of trying to tell them a little bit about what exactly is going on, okay? This is sort of the scene from our trauma bay. This is a scene of trauma bay television. People are much better looking in television. And this is what happens when it's over. I found it entertaining that JAMA Surgery actually asked people, surveyed people on how was your experience in the trauma bay? It's kind of like you've been to Jiffy Lube and they want to know how that went. How was your level 1 activation? So not surprisingly, not everyone was wild about it. I'll let you read that yourself. And the seniors have heard this repeatedly, but this is sort of an exchange that I have heard people in explaining to trauma patients what's going on. So frequently, you're the one who operates on the day they get injured, right? If we get some surgery right away, you're the one who does it, okay? But you're not the one keeping them alive. But if you go out to the waiting area and find out, first of all, you can find out their name, that's helpful. Because if you go out to the waiting area and go, can I have any family for trauma whiskey? That's like, there's a lot of judgment in that, first of all. Second of all, they may not know what their trauma name is, okay? And if you say this, you understand every sentence here. They don't understand any of it, okay? And so you explain to them, we have a system here, you're gonna meet, when you walk out to them, you start by, if it's true, start by saying, family member's okay for that. Okay? And the general surgery team, they sort of quarterback this whole thing. They're taking care of the mind members. Then go down to the ICU. He's still using the machine to breathe. And there's a lot we don't know. I'm just going to tell you what we do know. But people don't know, like to you, it's second nature what a chest tube is, or what a sick, what a SICU is. And to tell someone who has a sick relative or a sick child, God forbid, you know, we don't know how the head is. Like, it's accurate that you don't know how the head is, but like, that's terrifying, right? You're going to be honest, and you're going to explain things, but you need to explain things in a way that's a little bit sensitive. Not coming from me. So, yeah, so try to speak English, like, you know, lay English. Right? A quick word, I'm going to go through the trauma exam here in just a second, and a quick word on interactions. Your hip fracture is all going to be on the medicine service, okay? Most of your polytraumas are going to be on the trauma team. In excess of 70% of the operative interventions on trauma patients are done by orthopedic surgeons, okay? And these guys have to babysit the pre-osseous workup, okay? That's not that fun for them. I'm certain that's not why they went to medical school, okay? So, and you all do, but treat them with respect. Keep the fact in mind that this can be a source of resentment. The same goes to the ED team. We certainly are all susceptible to certain feelings of superiority relative to other people based on what we think the value of our intervention is relative to other people's interventions. None of you think that, but keep it in mind when you're interacting with people. And I would encourage you to interact with them in a respectful manner, even when it is trying for both of you. Fair? Okay. You all are invited to level 1 activations, specifically for the reasons we talked about. Is that being there at the beginning is benefits the patient in the long term, right? And when we go through the differential shock and that sort of thing, it helps the patient act with the physician, and also it helps your value in the system, in your interaction with the general surgeons, and in your interaction with the anesthesiologists. If you're not holding the EKG upside down and you show it to them, that kind of thing. But I'm joking. If you're more of a trauma surgeon than a fracture surgeon, I think that's helpful. It's helpful to your credibility. It's helpful to all of our credibilities. Okay. All right. Did you want to volunteer to be our trauma patient? Sure. That's great. All right. You're going to see. And I'm sure your seniors can go over this with you, but we're just going to go through this could be a super focused exam. On the issue of your interaction with the trauma service, when you're in the bay and there's trauma 1 activation, they're going to tell you when it's okay for you to be involved. They're going to occasionally say, no, we're going to scan you, cannot be involved, period. We stabilize limbs when we can, because it diminishes blood loss, it diminishes their requirement for morphine and other pulmonary compromising medicines, and it probably diminishes the amount of ongoing soft tissue damage. Okay, but you do what you can, and you will learn over the course of your time here that there's some people that are going to interact with you better than others, and you just do your best. Okay. The whole point of this is you can do a focal exam in less than 3 minutes. We're going to assume an awake patient. In an unawake patient, the neurologic parts of the exam are gone, but you can still do a physical exam of the body parts, right? So you can't do motors and sensory, but you can pretty much do the rest of it. Okay. So you start, and I'm going to prefer if you just don't act drunk. That's not always the case. They're collared, so you're going to skip the neck. Okay. So you start, just palpate both clavicles, feel it. And again, if they're awake, you may get an ow or stop it, but I already violated what I told you. Hi, my name is Dr. Higgins. I'm one of the orthopedic doctors. We're just going to check around. Just need you to cooperate with me for about the next 2 minutes, okay? Just want to make sure that everything is okay. Okay? I'm just going to start by feeling your shoulders here. Tell me if any of this hurts, right? And if they're not awake, you just range these If someone's got an injury, you're going to know just in that, right? The other thing is to see the downsides of the legs, right? Because if you got wounds on their downsides, you need to know about it, okay? And then you're going to develop in your head a neurological exam that just goes like that, okay? But essentially, there's five nerves in the upper extremity that matter, and essentially 3 or 4, depending on your math, in the lower extremity that matter. All right, I need you to push your elbow away from your side for me. Bring your hand towards your mouth. Push it away from your mouth. Squeeze my fingers. Straighten your fingers out. Make a 7 for me. Thumb up. Finish your thumb in the middle. Make a fist. Okay. Do you feel this here? 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 And here? Yes. You're just going to compress the chest in both directions, A to P, and be a little lateral. And did the opposite of what I said I was doing. Same goes for the pelvis. Try to compress it, and then get the crest, try to push the crest apart. They'll let you know if it's uncomfortable, okay? People sometimes worry, like particularly fat people, that they can't really palpate the pelvis. Or like it might be unstable or it might not be unstable. I think the first time you feel one is actually like open book unstable, it's not so. Okay. And then if it is open book unstable, just bind it up and leave it. Okay, don't keep repeating the exam. Okay. And then on the lower extremities, you're going to feel the trochs. You pick the limb up. You would prefer to be able to see the guy who's got scrubs on. You want to see their perineum, right? Especially if they have a pelvic fracture, you need to know that it's not open. And then you're going to see the rest of their downside when you roll them over, and you guys are going to be there. You see both sides. And then now straighten your knee out for me. Bend your knee for me. Okay, pull your toes up for me. Push your toes down. Can you feel here? Here? Yes. Here? Here? And here? Okay. And then obviously you assess a vascular exam, but that's not something the patients actually participate in. Dave, am I missing anything? Seniors, am I missing anything? You guys have done this exam more frequently in the last 5 years and a half. I'm sorry, John, I left out a little bit. What else? Yes. We're in this fatal state for it.
I think it was implied, but I forget if you actually did or not, but just make sure you're checking pulses.
Yeah, I just sort of said it verbally at the end, and you're right, I didn't do it while it's been for. Yeah.
The other part is they interplay of minute to work.
Yeah.
You should work on standing in the back. You want to get everything done. Let the general surgery teams go through their stuff.
And also, as you've been around a little bit and you understand the flow of it and they know you, yeah, then it's going to be easier to be more involved earlier. Right? And then when we talk about later in the summer, we talk about things like open fractures, talk about what prophylaxis you need for what we expect. Please don't say, yeah, we can rinse out open wounds, but that doesn't make them, it doesn't make it clean, it just makes it flat. Yes.
The other thing I would say is, especially in intubated or patients in extremis, like things happen really fast in trauma bay. I think it's tempting to take your exam and you get there and say that that's your exam. But I think a lot of these people need to be stated when they're not in trauma bay and more thoroughly than you can. And somebody who's a true level 1 trauma. So I think you can catch more injuries that way.
Great point, and that's part of problems people look for, sort of secondary tissue. Which keep track of that all. All right, sweet. Thanks, Dave. You're doing pelvis fast out in a second. Thank you. So That's not it. That's not it.
You get your information.
Usually NHTSA. And